Southern Railway's headquarters hospital. It gives me great pleasure and privilege to welcome you all. The topic for today's CME is based on compression-only life support. Just to give you an overview, the mortality of a sudden cardiac arrest in India is approximately 4,280 for every 100,000. And this is in big contrast to the United States, where you have only 60 to 150 for every 100,000 victims. And every minute delay in resuscitation of the victim reduces the survival chance of a victim by 7 to 10%, which is quite big. And that came around to giving the guidelines for compression-only life support, and hence it was developed. And large trials have also proven that compression-only life support is as effective as the conventional CPR when provided by a layperson. Having said that, we would like to extend a very warm welcome to all our dignitaries present here. Firstly, we would like to extend a very warm welcome to our beloved PCMD sir, Dr. B.P. Nanda. We request our medical director to invite sir with a bouquet. We would like to warmly welcome our beloved MD Madam, Dr. V. Nirmala Devi, as our patron for today. We also welcome all the other senior IRMS officers. We take great pleasure in inviting the CMS of Trichy, Dr. Soundararajan. The CMS of Madurai, Dr. Ganeshyan Sahu. And the CMS of Palakkad, Dr. Kalarani.
We welcome our Chief Cardiologist, Dr. Sriram Rajagopal, and Chief Cardiologist, Dr. Modi.
We would like to extend a very warm welcome to our beloved Head of Department of Anesthesiology, Dr. Kusma Matai. She is also the chairperson for today's meet. Finally, we take great pleasure in inviting our speakers for today, Dr. Bhaskar, Secretary of ISC Chennai, and Dr. Giridharan, Treasurer ISC Chennai. Finally, we take great pride in welcoming all our staff, our paramedical staff, and our postgraduates to the meet. I now hand over the dais to our beloved chairperson to begin the session.
Very good morning. Respected Principal Chief Medical Director, Medical Director, Chief Cardiologist of Southern Railway, and CMS of Madurai, Trichy, and Palakkad. Very warm welcome to all of you. I also welcome the speakers of today, Dr. Bhaskar and Dr. Giridharan. And as Ramya has told us, the topic of today is compression-only life support, and she has given a very brief introduction to why it is very essential. And so this will be the CME, and which includes interactive session, workshop, demonstration, and speech will be done under the expert guidance of Dr. Bhaskar and Dr. Giridharan. So I welcome both Dr. Bhaskar and Dr. Giridharan. And Dr. Bhaskar Natarajan is a professor, Department of Anesthesiology, Government Omangaluru Multi-Speciality Hospital, and he is also the Secretary of the Indian Society of Anesthesiologists, Chennai City branch. And Dr. Giridharan is the consultant anesthesiologist and the senior assistant professor, Department of Anesthesia, Stanford Medical College. And both of them have been experts and given a lot of interactive sessions under the aegis of Indian Society of Anesthesiology and Indian Resuscitation Council. And they have been going around and giving this demonstration on compression-only life support, which is very, very useful for not only paramedics and even the medics, for all the, so that any out of hospital situation also can be tackled when we see a collapsed person. So I welcome you once again, and please hand over the mic to Dr. Bhaskar. Thank you so much.
Railway Anesthesia Association for giving us the opportunity to demonstrate this life-saving technique, COLS, compression-only life support. being promoted by Indian Legislative Council body under the aegis of ISA. I would like to thank Dr. Kamat Sallan who contacted me regarding this program, and straight away we would like to start the program now.
Giridharan, I would like to present about the cardiopulmonary resuscitation for all of you. First slide please. Before going to the topic per se, I want to share a few terminologies which is new or which has been aware about the things. First slide please. So anesthesiology is a medical specialty concerned with the total perioperative of the patients before, during and after surgery. This is basically emphasis not only in the intraoperative and the theatre session, it also extended into specialties like intensive care, critical care medicine, pain management and subspecialties. Next slide please. So anesthesiologist is a doctor, which a lot of people when we go and talk in a peripheral setup, they have to understand, which is a basic qualification of MBBS and followed by a specialty exposure of 3 years like other specialties, and they get into the super specialties like cardiac, neurac, pain and so on. So we belong to the ISA Chennai City branch, and just a small introduction about the ISA. The Indian Society of Anesthesiologists is formed in the year 1947. Each doctor who is qualified as an anesthetist will be the members of the society, and their terms and fluencies has been discussed in the Society of Anesthesia, and they conduct regular CME activities, and for the past 4-5 years public awareness also has been one of the part of the program of the ISA, and it actually has an ISA national branch with the state branches and our in subdivisions as city branches. We belong to ISA Chennai City Chapter. So just a few words about anesthesia. General anesthesia has been performed in 1846 when W.T.G. Martin demonstrated the first anesthetics used in Boston in USA. This was in October 16th in 1846, which was in due course of time. It has been enhanced and celebrated as Ether Day throughout the world. Next slide. So just a few awareness about anesthesia. What is general anesthesia? It is described as reversible loss of consciousness. Any patient is taken into a state of unconsciousness during the surgery and get back to the normal. If there is any mishap, then it is coma. It is also the reversible state of unconsciousness with inability to respond to the surgical stimulus, which is because of the advancement of the drugs and the newer agents has been come into account. It comes from the French and a Latin word called sine qua non, which is unconsciousness for a transient time. Just being a staff and other member, I want to share a small thing. It was started in the era of Sushruta itself. When you can see some pictures of Sushruta period, that holding a person by 4 limbs, that is what is called as immobilization. They used to give a big bang in the back of the head, which causes a lucid interval, transient loss of consciousness through which they do the surgery, and they give little bit of opioids to the patient by making them to get pain relief. That was the era which was starting of anesthesia, and in advancement has come to a newer era, which is all comes into short acting drugs and newer agents which is on continuous infusions. The next slide please. So just to go about the descriptions, the basic Boyle's apparatus, most of the people should be aware of the types of anesthesia. So one is general anesthesia, which is called as complete sleeping, making the patient to sleep. That is mulu mayakama kodukkarathu, the patient will go to sleep completely. Then comes the spinal anesthesia, where we give the medication in the spinal column, so that half of the below your hip it becomes numb, so that the procedure can be proceeded beneath the places where it is paralyzed. And it is also transient, which will be regained. Then comes the regional, where a segmental part, that is a region of the body is being paralyzed, like upper limb, lower limb, where the blocks come into account. And next comes the local anesthesia, which comes as local infiltration of the skin and suturing and excision of small things, and tropical, like for cataract surgeries. And one more important thing, other than the anesthesia purpose, MAC has become a major important thing, monitored anesthesia care. Even if we don't give anesthesia, it is documented that any procedure is done by a surgeon, there should be an anesthetist by the side. The medical legal aspect comes into the account that in the insurance based all the things in present as well as in future, Whether the anesthetist is involved even for a local procedure is must. So NAC comes under the consideration stating that you monitor the basic parameters of pulse, BP, saturation and other things of the patient during the surgery. Next slide please. So now going to the topic per se, our topic today is cardiac pulmonary resuscitation. A cardiac pulmonary resuscitation is a life-saving technique useful in many emergencies including a heart attack or a cardiac arrest or a drowning patients where the patient goes for an arrest in which someone's breathing and the heartbeat stops. When the heartbeat stops and the respiration is stopped, the patient has to be reinitiated with the respiration and start, which is called as cardiopulmonary resuscitation. Next slide please. So just a basic anatomy and physiology of heart. So normally all we know that it is a right heart and a left heart, where the right heart receives the impure blood, that is the deoxygenated blood, and it is being pumped into the lung where it is oxygenated, and the pure oxygenated blood goes into the left ventricle and it contracts and given through the major aorta to the all parts of the body. So this is basically a continuous cycle of blood circulation which takes place in our body. That is, it's pumped into the heart, goes to the peripheries, come back again to the right heart, gets oxygenated and so on. This is what is called as a physiologically as a cardiac cycle. This is normally the heart rate goes around 70 to 80 cycles per minute. The next slide please. So hand in hand goes with cardiac is the respiratory system. Once the respiratory system is oxygenates the blood broadly, then the complete cycle is followed. So these are twins like things which go together, and as an anesthetist we describe the respiratory system as to upper airway and lower airway. The upper airway comes from the sinus up to the trachea, and the lower airway from the trachea to the bifurcation of the tracheal generations of the segments to the peripheral alveoli where the gas exchanges occurs. That is, the blood is getting oxygenated. Next slide please. So what is the definition? If you see, it is cardiac pulmonary resuscitation is a technique of a basic support for oxygenation of the brain and the heart until the appropriate definite medical team takes up or regaining of the arrest system. So what is the significance is the main organ is going to be the brain, which has to be continuously supplied with oxygenated blood so that to avoid irreversible damage. What is the purpose? Our idea goes about all we say is routine thing A, B and C. A is airway, B is breathing and C is circulation. And the newer and one more important thing when the medical team takes over, it is the drug and other things which is going to be the act. And to say about A, you have to maintain the airway, make sure that the airway is patent and without any secretions. Once the airway is patent, then you can enhance or progress into the state of breathing, which can be done to the patient. The third is going to be the cardiac massage. These three things are the basic things to save the life of the patient. Next slide please. So we know, generally we think about cardiac arrest, we know the patient has arrested, but there are a lot of mechanisms which are there in the arrest. One is ventricular fibrillation. There should be a normal contraction which should pump the blood each and every time about 70 to 80 ml per contraction. So what happens if the heart fibrillates? It doesn't contract, just moves a flickering like thing. So the blood is not pumped out and the achievement of the blood circulation is not achieved. This is one type of arrest. And the next is going to be ventricular tachycardia. There is a normal heart rate, everyone knows it is 60 to 100, and you can go to an error of around 20 to 30%. A normal static say that a standardized good heart rate is 220 minus age, which is called as Reynolds thing, which is if the patient is pediatric, then 220 minus age is going to be, so we think 160 is a very bad heart rate for old people, but the same 160 is a good, which is an accepted heart rate for a child. So the mechanics goes, the children they depend on the heart rate, whereas the adults they depend upon the contractility to pump out. So when there is a ventricular tachycardia, which is we have to control that also, because the heart demand is going to increase because the heart is working more. So more blood is required, so more oxygen is required. So the demand increases, which in due course of time it becomes fatigue and naturally it goes into an arrest. And one more important thing is asystole, which there is no movement of the heart, it is completely in a astatic phase. And one is called as a pulseless activity. The heart contracts but there is no output. So that is called a pulseless, because when there is no output, it is not felt in the peripheral pulse, which is being we palpate in the radial pulse or femoral or whatever may be. Next slide please. So as I told, these two things go hand in hand, because once the heart doesn't pump, the respiratory system doesn't act. If the respiratory system doesn't act, the cardiac cannot pump. So the causes, whereas if there is a cardiac arrest, it goes for the respiratory failure. When there is a respiratory failure, it goes to the cardiac arrest. And this may be occurring like drowning. When the lung is filled with water, then there is no oxygenation, no air gas exchange occurs. So automatically it goes for a cardiac arrest. Stroke, a foreign body which goes into the throat, where our protective mechanism is cough. Whenever we have a foreign body entering into our trachea, we try to cough it out. It's a protective mechanism. And the trachea gets holding of the breath so that it won't go further. Once the foreign body goes deeper and deeper, it is difficult to be eliminated. So what is a normal cough is a forced expiration, that it pushes out the foreign material outside the trachea. So that when the foreign body irritation gets struck, the whole spasm occurs and the lung becomes static. So they go for an arrest. Drug overdosage like narcotics, sedatives, which goes and depresses the cerebral center, that is the respiratory center, which causes respiratory paralysis and gradually goes for a cardiac arrest. And other things like smoke, which causes suffocation, which causes gas exchange loss, and accident injuries where there can be aspiration, and so on. Next slide, please. So what is our major idea is to restore the circulation when there is an arrest and to restore the respiration. These are the two primary components of our idea. So we have to restore the circulation, because then only the blood from the right heart goes to the lung, then to the left heart, then goes to the circulation. The idea to going to the lung is for oxygenation. So once there is a circulation, it causes the flow. Once there is an oxygenated, it causes the flow of oxygenated blood. So that there will be an irreversible damage of our brain because of anoxia or decreased oxygen supply. Next slide, please. So what is CPR procedure? A sequence of procedure which has been performed to restore the circulation, what I told already, just to brush up back again and again, because this is the basic concept, to regain circulation and to regain the oxygenated blood circulation to the vital organs to cause an irreversible damage. Any compression which can, chest compression, we can externally a pressure is applied over the heart to pump up, and the forward flow of the blood itself will move to the lung so that it will be oxygenated. So next slide, please. So these are the headings which we are going to talk as a protocol of CPR. First is approach safely. You have to approach the patient safely, then check the response of the patient and shout for help, open the airway, check the breathing, call for the next medical support, that is 108. You will not go on do on CPR, because the next thing is going to be the patient should be transported to a hospital through the ambulance with all the facilities available. And till the other facilities available has reached, you have to go for cardiac compression, is to respiratory support also. Next slide, please. So very simple, we will go in detail with each and everything. Approach safely. So what is approach safely? When you see the patient arrest, everyone goes and see around the patient, try to crowd around them. That is not the first thing. Make the patient comfortable. You have to have a free circulation of air. So make the people go away at least 2 to 3 feet away from the patient so that they will be exposed to fresh air. And the people who are trained or oriented to resuscitation should do the resuscitation by the side. So not like all going and trying to do. So 1 or 2 people at the most. One is for cardiac compression and other for the respiratory resuscitation. Next slide, please. So check for response. I want to share a small incident which happened in my institution itself. So we had a post-operative patient in our post-operative care. The patient had little bit of secretions. A house surgeon who was on the first day to the OT came into that. He said they found the secretions. The patient was actually came out of general anesthesia, was sedated. There was little bit of secretions in the mouth. The house surgeon went immediately, found the secretion in the mouth. He called the patient. He saw the patient unresponsive because of sedation. He called the staff. The patient is arrested. There was a call, and the house surgeon, the staff started respiration. The next moment when I went there, I found the pulse there. Then I asked the patient what happened. I don't know, someone is compressing on my heart. So the patient was not arrested, but CPR was done. So don't think it's a joke, it actually happened. So before doing that, you should make sure that the patient is arrested. That is our prime idea. So check for the response. Next slide, please. Verbal check. You call the patient, are you okay, or whatever by language they know, you call by name if you know by name, or by the thing. So if you are not oriented to the language, then shake the shoulders or shrug the shoulders gently. Don't be so harsh. So you should not cause, patient can be arrested due to trauma. That time you cannot go and cause, moving the shoulder, it can cause some cervical dislocation, already has some fracture. So gently shake the patient, call the patient, ask the patient, are you okay? If he responds, he is not arrested. So if it is a medical team, they can see the pulse and all. But as a lay person, this is basically an idea for a lay person who goes for a cardiopulmonary resuscitation. So if he is fine, leave him alone and call for the team and ask them to treat for the problem what he has been facing. If it is wrong, then reassess regularly. Once you start the resuscitation, don't go on doing the resuscitation. Our idea is to regain the cardiac cycle and the respiration. Intermittently, we have to check the patient as whether he has regained back to the conscious status and the respiration status. Next slide, please. So basic idea is take the patient's spine, have a head tilt. You have to make the patient tilt above and lift the chin so that you make the airway open. And you keep the hand at the angle. That and the elumbukku pinnadi, if you give a compression and lift, automatically the mouth opens out. So once the mouth opens out, the tongue opens out, then the airway becomes patent. So that is our idea to do this maneuver. Next slide, please. So once you start this doing things, simultaneously you call for help because you require 2 persons for resuscitation, which I will be dealing about in due course of time. Then, next slide, please. Open the airway, as I told, by the head lift, jaw thrust and chin lift. Then check for breathing. You have to check, next slide please, check for breathing because we should know whether the patient is breathing or not. So what next, previous slide. So you have to check for the breathing. How to check for breathing? Next slide please. So first you look for the chest movement. So if you see the chest, if the movement of the chest is there, then the patient is breathing. Some obese patient, you cannot make it out. Then go near the oral and the nose, mouth or the nose and hear for it. So if you can hear the breathing also, second thing. And third thing, you can keep the dorsum of hand in front of the nose or the mouth. So you can feel the warmth air, which is the expired air, which touches your dorsum hand, so that you can identify whether the patient is breathing or not. So you have to differentiate about a breathing which is not normal. When you see a patient who has aspirated or arrested or lying unconscious, but there will be breathing. You should know whether there is a normal, smooth, regular breathing or abnormal breathing. Next slide please. Which is called as agonal breathing. So this usually occurs when there is an airway obstruction, or it occurs shortly when the heart arrests. When the heart arrests, 40% of the cardiac arrest after the arrest there will be a grunting respiration or a paradoxical respiration of the abdomen and the thorax. And one more thing, you can see a snoring like thing. So you have to be more particular to identify that. In due course of time it go for a respiratory failure. So it is barely a heavy noisy breathing or a gasping. So it will be a deep breath followed by a gasp. That is called a gasp. Like once it is recognized, if there is a cardiac arrest, then goes for the CPR. Next slide please. So our idea is to call the medical team. You start your CPR and call for 108. Next slide. So then our idea is going to have a cardiac compression. That is it is always a 30:2. That is the prior thing which has been done is 30 cardiac compression with 2 live breaths. Next slide. So how to go about a cardiac compression? Place the heel of one hand in the center of the chest. Place the other hand on the top. Interlink the fingers. Compress the chest. The idea of compression should be at a rate of 100. And the depth of compression should be 4 to 5 centimeters towards the spine, and then the moment you do the compression, you allow the recoil. That is more important. People go on doing compression deeper and deeper and deeper. It is not the thing. You have to give a compression and you have to get back the relaxation. Then only the heart contracts. Once it relaxes, it has to pump blood. So the cycle should be regained. Our physiology, what the heart does, should be done from the external maneuver. Then what you have to do is you change the position. So you do a cardiac resuscitation. You give a cardiac compression. Do for 2 minutes and change over to another person, because fatigability will decrease the efficacy. Our idea of efficacy is at least you require 50 to 60% of the cardiac contractility to maintain the blood circulation for the brain, because brain is going to be the vital organ. and I will be discussing about the irreversible damage of organs in later stages. So for avoid fatigability, change the cycle. You do for 2 minutes, then call your other person to do for 2 minutes, and you change yourself so you will not become fatigued so easily. Next slide please. Then comes the 2 rescue breaths. So 2 rescue breaths, 30 compression followed by 2 rescue breaths. Again 30 compression followed by 2 rescue breaths. Before going for the rescue breaths, you have to know what you have to do. You have to pinch the nose because you cannot blow through the mouth as well as through the nose. And once you blow through the mouth, it should not come through the nose. So idea behind this is pinch the nose and blow through the mouth and take a knot before blowing. So what you have to do is you have to take a deep inspiration so that you have to fill your lung with an extra gas. So then only you can have a forcible expiration which will go into the patient. So take a normal breath or little bit a deeper breath, place the lips over the mouth, blow until the chest rises. Once you blow, you can visualize the chest on the side so that it has to expand. If it is not expanding, then there is obstruction. So make sure that you have to clear the obstructions also. So once our idea is gas should go into the lung or the expired air should go into the lung. So the idea will be by visualizing the expansion of the chest. And one more thing, take about 1 second for the blow. So once you do a blow, so that the normal respiratory, you can see the heart contracts 60 times per minute and your respiratory rate is 12 per minute. So it comes in a ratio of 1:4. So you take 1 second for your inspiration and the expiration will be slow for 2 to 3 seconds. Then there will be a pause. So each minute will have 12 to 16 respiratory rate, which each respiratory cycle will be 4 seconds. Our inspiration is one which is active, which we blow, and the expiration is a passive, which is backed by the recoiling of the chest cavity. You have to repeat 2 breaths. Then go for cardiac compression. Right? Now the rescue breaths. So once the idea is a normal rescue breath should be given around 500 to 600 ml. What is the idea behind this volume? So roughly we keep a patient of around 50 to 60 kg. That is our normal average Indian weight. So our vital capacity of the lung or the gas exchange of the lung is 7 to 10 ml per kg. So the patient is 50, then 500 ml. So you have to blow in 500 to 600 ml of air and give each breath over a period of 1 second for inspiration, and it has to be given back as a relaxation for 3 seconds for the air to come out. Then you give the next breath. So then you do the chest compression. Chest compression is done 100 times, 30 compression, 2 breaths, 30 compression, 2 breaths. The cycle is continued on and on. So next slide please. So continue CPR, do CPR. So what are the possible complications? Because we try always in anxiety or in emergency, we try to overdo things. So our problem with the human being is we overdo things. So we try to give more compression, more force, and all the problems occurs because of this. What are the problems will occur? You can see there are being reported injuries to the coronaries. When you give a hard cardiac compression, coronary injury has occurred. Once you increase the chest cavity, the pressure increases in the chest and will be transmitted down. The diaphragm which separates the thorax and the abdomen is ruptured. Because of the rupture, there develops hemopericardium, there is blood around the heart, hemothorax, blood around the lung, and these 2 things will have an external pressure or restriction of our idea, because our idea is to contract the heart. When the blood collects around the heart cannot contract because it gives an external restriction, and your idea of CPR is lost. So be careful while doing CPR. Next slide please. So other injuries are like liver injuries, pneumothorax, air around the lung, rib fractures. Rib fractures are more common because the force applied, which for the first time an enthusiastic doctor or a staff who does a CPR. And one of my favorite teacher during my undergraduate used to say, if you do 2 or 3 rib fractures, then you have learned CPR. So it is maybe funny, but it happens. When you take about 10 houses in doing a CPR during arrest, not on a mannequin or on a trial, on a real arrest in a ward, you can find out 2 to 3 rib fractures in 2 or 3 patients rib fractures are in. You develop by practice. This you have to develop, you know how much amount of pressure you give, and it varies from person to person. If the patient is obese, you need more pressure. When a patient is thin, you require less pressure. If it is going to be a child or an infant, you do your compression not with the not with the hand, with the thumb, which all you know when you see it in a newborn. So next slide please. So now we have a rough idea. So two things I want to say before going into the questionnaire pattern. What I want to say is why COLS, compression only life support, come more active. So a lot of people will do compression because it is more comfortable for us. So we have a good compression, we can give good cardiac compression. But how many of you in this room will go for respiratory support? How many of you will give mouth-to-mouth breathing? Can you put your hand? Or how many, I have given a mouth-to-mouth breathing for a 65-year-old lady in my house surgeon period. I was forced to give, because when you give for that age or for the place, then you will not have an hesitation in an emergency. So I was forced to give a mouth-to-mouth breathing in my unit M6 in Stanley. My chief was Damodaran at that time. He forced all house surgeons to give mouth-to-mouth breathing in an arrest in our unit. So I was trained like that. But now I can ask, how many of you have given mouth-to-mouth breathing, or how many of you are willing to give? You can put your hands. Willing to give. First we will go, how many of you have given? So how many of you are willing? So see, in a medical faculty or in a staff faculty or a students which are going upcoming staff faculties, we have a foot back to give a mouth-to-mouth. It depends on all things because of the hygienic purposes, because of the situations and all other things. So in abroad they had mask for ventilation. So all the resuscitation, you have a mask which is available on all the places in the emergency meeting points like a mall or an airport. So you can pick up the mask, keep the mask, and you can blow through the mask. So but in our country the awareness is not that much and CPR is not that practiced. So this is not been here. So what has happened in evolution, what they say is if you compress the heart, it has to go to the lung. And because of the activity by the cycle, which is going to be discussed by Dr. Bhaskar, how that blood gets oxygenated. So at least 40 to 60% of the patients can be supported only by cardiac support, cardiac compression only. So now we go. How many lives saved by CPR? Because our idea is doing CPR, we should know what is our results. So whatever we do an exam, all we are writing our exams, we need a result. So how many of you think, you can roughly say what is the life percentage saved by a CPR on an arrest in an average year in the world? Anybody? Yeah, guess. In percentage, any values? We want to achieve 100%, that is not possible. So next slide please. 40%. So you are saving 40% of the patient's life by CPR. So out of 100 arrested, 40 can be revived. The cause may be different because it can be a reversible cause or a very bad cause. That is we don't want. An arrested patient can regain. A single cardiac thump will regain the cardiac. I said one of the causes is asystole. When you give a thump, automatically it triggers and starts. That is more common you see in pediatrics and child because they want to thrive, to live. They want to live actually. So roughly 100,000 to 200,000 are lives saved every year. See the number, we think it is very simple, but all over the world in a year a cardiac arrest revived patients are going to be 100 to 200,000, which is given by US statistics. Next slide please. So when should we perform CPR? Anybody? Of course, there is an arrest. When there is a cardiac, next slide. When there is a cardiac and the respiratory arrest, you have to do a CPR. Once the heart arrest, you start the CPR. Next slide. So how do you know that someone needs CPR? Next slide. So person is unconscious. First make sure that call whether he is alive or not, call. Then here listen to the breathing. Then no respiration is there. Then cardiac arrest, CPR to be started. Next slide. What are the steps of CPR? Next slide. Just to regain. Position of the patient. Position of the hand on the chest, interlocking of the fingers, chest compression, the depth is important, 4 to 5 centimeters. Then make sure that the airway is open. Once you open the airway, you give a rescue breath. Watch for the chest movement because your entity is to achieve chest movement or the air going into the lung. Repeat chest compression twice, then go for cardiac compression 30 times. Next slide. What is the ratio? Already told. Next slide. So cardiac compression is the rescue breath ratio is 30:2 in adults. In pediatrics is 15 because pediatric are depend on heart rate because they have less reserves. the child has a less reserve volume of the lung. So average speed of a compression is 100 to 120. Why? A lot of people may have an idea why 60 is the normal heart rate, why we give 100 compression. Because a normal contractility we are able to achieve only 50 to 60%. So you double the rate. So that the idea is the blood circulation is fastened. Next slide please. What is the critical time to start CPR? Next slide. So CPR to be started as early as possible. Make sure the patient is arrested and start it as early as there is an arrest. Then CPR should be started within 3 minutes of the cardiac arrest. Why is that 3 minutes specifically? The reason is the brain ischemia time. A brain goes for irreversible damage in 3 to 5 minutes. So you have to start as, so you would have regained the heart and the respiration, but we say the brain death. So they say the brain is dead. So the resuscitation should be for the brain first, not for the vegetative state of the patient after the resuscitation. Mortality increases by 10% in every 30 seconds. Next slide. So when should we stop CPR? Before going to the next slide, I want to ask this. When to stop CPR? What will be your idea? When to stop CPR? Very good. Next. I would like a better answer. Don't stop CPR. Idea is right. Return of the respiration and the cardiac thing. But if the arrest is continuing, don't stop CPR. CPR should not be stopped. Continue. Give try for the life to regain. Next slide please. So when the heartbeat and the respiration regains as told prior, when the patient becomes conscious, when the emergency teams comes so that you can hand over the patient to the team, when you become fatigued trying to change to another patient. The motto of CPR is never stop CPR. Try to give at least 1% chance for the patient to get back to life. So we go by emotions. Whenever, even in medical faculty, after death, the doctor will come and say the patient is died. Even a doctor, when his relative or his near one, dear one has the incident, we ask the same. Even I asked the same when my mom died. So that is more important. Never give CPR. Next slide please. So how long does the organ, this is more important. So what is the efficacy of CPR? So these are the things, what are the types of CPR, how to do a CPR, what is the idea of CPR, what is the regaining capacity of CPR. The main idea is what is the efficacy of CPR depends upon the survival of the cardiac arrest. Organ circulation is important because of our CPR. Next slide. So first and foremost is going to be brain. So that is the reason we should start CPR as early as possible within 3 minutes. Brain ischemia time is 4 to 6 minutes. If it is going to be more than that time, then there is going to be a reversible brain damage or and even the efficacy is less. It is going to be a hypoxic or decreased oxygen damage to the brain tissues. Then comes the heart. The heart can survive ischemia for 15 to 20 minutes. Then the kidney, which goes to 4 to 6 hours, bones 8 to 10 hours. The circulation stops. When the circulation stops, the blood clots in 6 hours. So that is the principle. You have to do CPR as early as possible to regain the organ efficacy. Next slide please. What are the complications? Already we have dealt. Fracture of the rib. Next slide. Fractures, hemothorax, pneumothorax, injury to the heart, all the vital organ. Next slide. So what are the numbers? We should know. What are the numbers we are going to deal with in case of emergency? All we know, because of the great ambulance scheme which has come in Tamil Nadu, everyone knows to call the number 108. Next slide. So you have to be aware of other countries little bit. UK it is going to be 911. US is 999 112. Next slide please. So very nice to hear, all being attentive, not sluggish like an arrested heart. All faces are flourishing like a resuscitated heart. Thanks once again. Or we'll deal the questions in the last. So we'll deal the questions in the last totally.
Good morning everybody. I should first thank Dr. Giri for giving an elaborate lecture on CPR. So first of all, I want to ask, my part of discussion is COIL, there is compression only life support. So what is the language you are all comfortable with? Shall I continue with English or Tamil needed? So because it's the railways, there are going to be staff from both sides. It will be all India staff. So If anybody wants to have any clarification in Tamil, I can also give that also, but basically we'll directly go for an English version. So Dr. Giri has very clearly told that CPR, and he asked a very important question: how many of them are ready to give a mouth-to-mouth breathing? So the Indian Resuscitation Council, under the aegis of ISA, after going through lot many studies, they have found this one mouth-to-mouth breathing is a hurdle in reviving or anybody trying a CPR at a common scenario. See, if a patient arrests in a roadside, they are ready to give a chest compression, but not ready to give a mouth-to-mouth breathing because there's a taboo attached with it, and we don't have barrier devices, not freely available. So what they have found is, at least you give chest compression, the residual oxygen that is, you can start the slide, sir. The residual oxygen that is within the blood, it is going to be circulated, and you are going to immediately call for a help, and a medical team is going to arrive. So, and he has clearly told within 4 to 6 minutes the brain is going to go for a irreversible damage. So we are going to prevent that. So the vital time, as early as possible, you please start your resuscitation. So that is the idea behind this program, that is COLS, compression only life support. Compression only life support is being promoted in India. This is not, you cannot see this COLS in abroad. They directly go for BLS, that is basic life support, that is airway, breathing, compression and defibrillation, because in abroad, in main areas, they have defibrillator everywhere, whether it's going to be a mall, cinema theater or even a road, they have separate column to have defibrillator. So they don't have a program like COLS. It is only BLS or ACLS, that is advanced cardiac life support. Only in India, what we have found is, we have a very big population. We cannot, the doctor population is very much less compared to, and they are concentrated more in the urban area. So rural area, the doctor population ratio is very less. So they want to cover that deficit. So Indian Resuscitation Council wants the common man to participate in BLS. This idea of COLS, even a common person, even a rickshawala or even an auto driver or any lay person who knows that a patient has arrested and is ready to give a cardiac compression. We are not bothered about a rescue breath. We want only cardiac compression, and he has to call immediately for help, and the help arrives, they take over. They will immediately switch over to the BLS. For example, if an arrest happens within this premise, what is expected to be given to the patient is BLS. Fine. BLS, the most important component of BLS, the fourth point is the defibrillation. But there is no defibrillator here. At least you can start a COLS, that is compression only life support. You start compression. You can give a rescue breath. If you have an airway, you can put it and you can give a rescue breath. Okay. So at least you start with the compression only life support and immediately progress to BLS and then ACLS. Why? If a person arrests at the gateway of this hospital and auto drivers see a person as arrested, immediately if he is going to call for help, a doctor team arrives, it will take minimum 10 minutes. 5 to 10 minutes is expected. It's a normal time to happen. So if the auto driver knows how to give compression, then he can start COLS. He can save that life. That residual air, that is oxygen that is in the blood, is going to be circulated by just giving compression to the heart, and immediately the BLS team will take over. So this is the idea, though we want to go for the infrastructure level. We want the common people to come and take over a part in this resuscitation of the heart. So compression only life support basically is designed for a lay person. We are all technical person when we are in this hospital. Now, if I am in Abhyani theatre, I become a lay person. There is no defibrillator. At least I can give a compression only life support. Okay, so don't think that COLS is for layperson. I am a staff nurse here. I am a staff nurse in Abhirami Theatre, so I will give only BLS. Okay? At least you can start a COLS and you call for help. Okay? So these are small pre-lecture tests. What are the intervention of cardiac arrest in early stage of, will it give it a good result? Yes. And cardiac arrest happens only in hospital? No. Can even happen anywhere, even in your house, anybody's house it can happen. Fine. After identifying a cardiac arrest, you will have to immediately shift him to hospital? Yes. But at least you have to start the COLS. Okay. Next. Only doctor are entitled to take the cardiac arrest? No. Anybody can start a cardiac compression provided he is trained. Non-medical lay people should not give cardiac massage. No. It is, yes, a lay person can give a cardiac massage provided he is trained for COLS. Okay. Next. Uneducated people should not give cardiac massage. It's not like that. If he is trained in COLS, yes, he can do. We need lot of people to give cardiac massage? No. Only one person. He can do that. Next. We need sophisticated devices to give cardiac massage? Not at all. Just 2 hands enough. We have to give cardiac massage to pediatric cardiac arrest or victim of drainage or asphyxiation. These are the places that you should not give. You should avoid giving a cardiac massage. You have to bring out the patient to a safe area. These areas, because the patient is drowned, already there is lung, it is water in the lung, and if you are going to give a cardiac compression, everything, it is going to aspirate, it is going to worsen. So these are places where you have to avoid. And after this program, you should be, I think the last answer is yes. I will be bold enough to give a cardiac massage. Next slide. So this is the circle of life where early recognition followed by you call for immediate help, then early high quality CPR, which he has told very correctly. You have to correctly identify the cardiac compression point, adequate compression 4 to 6 centimeters, adequate recoil time, and you have to give at least 100 to 120 compression within a minute, and rescue breath if it is a BLS. If it is COLS, no rescue breath at all. And then go for early defibrillation, because 3 common type of reason for arrest is either the ventricular fibrillation, ventricular tachycardia, or asystole. Okay, and early comprehensive life support, this is the last one. Then going for drugs. Next slide. So these are the difference between COLS, BLS and ACLS. COLS is for lay person, out of hospital scenario. BLS is a trained medic, and that is where you have ABCD. That is, now it is changed to CABD, circulation, airway, breathing and defibrillation. And advanced cardiac life support is ACLS. Next slide. So compression only life support. Who can give? It can be given by a lay person, out of hospital cardiac arrest. Emphasis is given only to high quality chest compression. No need for rescue breathing. Continue till the health provider arrives at the scenario and takes over the care of the patient. And promoted, this is being promoted by the Indian Resuscitation Council under the aegis of ISA. Next slide. So how it works? External cardiac massage, if it's going to be given correctly, can maintain around 20 to 30% of the blood flow to the vital organ, and the residual oxygen in the blood will avoid no oxygen demand. Already the patient has gone for arrest, his oxygen demand is going to be come down. So even that, the limit, that little amount of oxygen that is already in the blood is going to help him. Okay, next slide. So when not to perform COLS, don't perform COLS. The scenario is not safe for you as well as for the patient. So try to remove from that place. And patient, if is going to be responsive, don't try to give a cardiac massage. And drowning patient, asphyxiated patient, or suspected opiate poisoning, all these patients, because these patients are prone for asphyxiation. Okay, next slide. So things to be needed during performing of the COLS: no medical equipment is required. Confirm the cardiac arrest or respirator by checking the corrected pulse and no respiratory attempt. Assure the environment is safe to provide the COLS. Ask the crowd to move away, as clearly told, at least 2 to 3 feet. And don't waste timing a video recording or taking a selfie. I have seen a cardiac arrest, I am doing a COLS. Please don't encourage those things. we tell the people to move away. Next, ideal if you have 2%, if you have even the 1%, please start and immediately call for help and do it in a calm, composed and confident manner. Okay, next slide. So this is the, it's very small. You first ensure the safety of the place, followed by the check response, whether patient is going to be responding or not responding. If he is responding, you move him to the medical unit or call for help and in a safer place. If he is not responding, call for help, ask the people to call for 108 and immediately you start. You first check for the carotid pulse and the respiration. If it's not there, you immediately start for chest compression, 30 compression. 30, 30, 30. You have to count loudly. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You have to make at least 100 to 120 compression within a minute. And you have to give adequate recall. See, this is a laborious process. Your energy will drain like anything. I will do a demo. You can see how much I am going to sweat like anything. So this, if you are going to do it, you have to do practice with the mannequin regularly. Then only you will know whether you are giving an adequate chest compression. And if there is going to be 2%, the outcome is going to be very good. And after completion of 2 cycles, you check for response. If no response, you continue the cycle. If he is responding, moving to the rescue position. Next slide. So site of compression is 2 centimeters, that is 2 finger breadth above the xiphoid. That is the xiphoid process. 2 centimeter above that is the center of chest, or between the 2 nipples, usually tell. And you have to keep the both hands, the left hand interlock with the right hand at that place and give at least 100 to 120 compression, and the rough calculation is around 30 compression in 15 seconds. So 1 second, within second you have to make 2 compressions. Just it's mind boggling. 100 to 120 is compression within a minute and 2 compression within a second. Just within this you have to complete a 2 compression. So this is the amount of compression you have to, the rate of compression you have to do. And there should not be no interruption. While doing a compression, don't try to go and check the carotid pulse. Okay? And the force should be directly transmitted. As you seen in that figure, it has to be directly from the shoulder. It has to come directly to the chest. There should not be bending at the elbow. And if the second person is available, go for rotation. Next slide. Once the patient is recovered, you put it in the lateral position. We all know that the recovery position or anti-aspiration position. Okay. Next slide. So when to stop? Already told, when the medical help comes, or when the patient becomes responsive, or when the place becomes unsafe. You have started a CVLS, you see a building is collapsing. Please don't be a hero and continue doing CVLS. You just move away with the patient to a safer area, then you can continue. Okay. And if you are fatigued, you have the rescuer available, you can change and continue till the spontaneous circulation starts. That is, we used to tell it as ROSC, that is return of spontaneous circulation. You check with the carotid pulse, and you are not allowed to check the carotid pulse more than, anybody knows? So where you will check carotid pulse? Yes, one. Staff. So this area. Okay, simple. As sir correctly told that at the level of thyroid cartilage. Okay, next slide. So what are the complications? You already told that the blood can accumulate around the heart or in the lungs, or air can come, damage, there could be rib fracture. Next slide. Next slide. So after this, you all know the answer. You should be telling that I will be confident enough to be cardiac. We have brought the mannequin. We'll do a demo, and you also get trained. Then only you will not have any hesitation when you see a patient collapsing. Okay, next slide. So this is a video. Video switch on பண்ண முடியுமா? Video வருதா? Yes, this video I got luckily this happened some 6 months back, where you can see a doctor. She, after her routine work, she is doing a prescription, she is getting a headache, she collapsed. Okay, this is the in-hospital scenario. Okay, you see what's happening there. 5 seconds gone, 10 seconds gone, 15 seconds gone, 20 seconds gone. See, each and every second we are allowing, we are not doing anything intervening, we are losing the patient. The patient is going for a irreversible damage. See, almost 30 seconds gone. This is a in-hospital scenario. What I am putting a video is just a in-hospital scenario. Almost 40 seconds gone. She lost her. We lost the doctor. Okay. See, almost 1 minute gone. See, we have seen all medical professional coming there, lay person coming there, nurses coming there. Nobody did anything and we lost the doctor, unfortunately. Okay. Yeah. Yes, sir. Sir, can you switch on this next slide, next video? See, this happened 3 months back in an airport at Bombay. See, one person collapsed. It's a CSF, that is Central Industrial Security Force person who knows CPR. He immediately rushed to the spot. He moves everybody out and he has started just compression alone. He has not even given rescue breath. And the happy news is the patient survived. He got his circulation back, and this patient was immediately shifted to a hospital, underwent a cardiac procedure, and is alive. The first one is a in-hospital scenario. The second one is out of hospital scenario. The first one, all doctors available. The second one, no doctors available. There we lost the patient. Here we saved the patient. Sir? Sir?
Is there any defibrillation done?
No, sir, nothing, sir. Just anything, sir. At least he has started. Patient came out and was immediately shifted out. He was immediately taken to the medical team. One at somewhere, I don't know what is in Bombay. They immediately took over the patient and he was saved. So, with this I will end this small lecture. I thank you all for your patient listening. And we have got the mannequin. So with this we'll do a demo. I request all the members to come and get a hands-on experience. Thank you. Any doubts? Now it's open for discussion.
On the table பின்னாடி
Cordless mic. Cordless mic.
and a label. Now I have been trained. I am going to start 60% CY. So, CY process. Go finger, go into the right hand and left hand. Okay? And this should be directly transmitted. Yes. And I should ask somebody to have a count. Or 1 minute we have 20 seconds. Take this process. 120 compression. Okay?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3 and so on. So the more important thing in giving a compression is the pressure should be directed from the shoulder to the hand. At the wrist. At the wrist. The elbow should not bend. That is more important. That நம்மளுடைய pressure வந்து டைரக்டா ஷோல்டர்லேருந்து டிரான்ஸ்மிட் ஆகணுமே தவிர கையிலேருந்து டிரான்ஸ்மிட் ஆகக்கூடாது. ஸோ அப்போ தான் வந்து ஈவனாக இருக்கும். அந்த ரிக்வயர்ட் ப்ரெஷரை வந்து நம்மளால கண்ட்ரோல் பண்ண முடியும். நம்ம எல்போ பெண்ட் ஆச்சுன்னா நம்மளுடைய ப்ரெஷர் டிரான்ஸ்ஃபர் வந்து குறைஞ்சிடும். Degree of compression. We said actually முதல்ல சொன்னது வந்து 4 to 6 centimeter inside.
Almost 120.
120 கிட்டே நான் தாண்டி இருக்கேன். ஆக்சுவலாக யாராவது 1 minute டைம் பார்த்துருந்தீங்கன்னா நான் எவ்வளோ கம்ப்ரெஷன் பண்ணுங்க. இந்த ஒரு சைக்கிள் முடிக்கிறதுல நீ எவ்வளோ பிரீத்திங் வாங்குறாங்க.
So that is the reason 2 minutes
So
you
have to rotate. So இது இந்த மேனிக்கனோட அட்வான்டேஜ் என்னன்னா when you give the compression, when you hear the click sound, it means that adequate compression நீங்க பண்ணியிருக்கீங்கன்னு அர்த்தம். And I given adequate time for recoil. சரிங்க, ரீகாயில் ஆகணும்னா அப்போ தான் பிளட்டு பெரிஃபரலாக இருக்க பிளட் வந்து உள்ளே சக்காகும். அந்த நெகட்டிவ் ப்ரெஷர் வந்தால் தான் உள்ளே வந்து சக்காகும். சரிங்களா? ஸோ அடிக்குவேட் ரீகால் டைம் கொடுத்தாங்கன்னா அடிக்குவேட் கம்ப்ரெஷன் கொடுத்தாங்க. ரெண்டுமே முக்கியம். அண்ட் ரேட் 100 to 12. இப்போ நான் ஒரு 5 சைக்கிள் பர்ஃபார்ம் பண்ணுறேன், இன்னொரு 5 சைக்கிள் பர்ஃபார்ம் பண்ணுறேன். பேஷண்ட் ரெஸ்பாண்ட் பண்ணுறாரு, காஃப் பண்ணுறாருன்னா பேஷண்ட்டை தட்டி எழுப்பிட்டு என்னன்னு கேட்டுட்டு ரெஸ்க்யூ பொசிஷன் போகணும். அண்ட் கால் ஃபார் ஹெல்ப் வந்து டேக் ஓவர் பண்ணுவாங்க. இன்கேஸ் எனக்கு வரல, எனக்கு டயர்ட் ஆகிடுது, அப்போ இவர் டேக் ஓவர் பண்ணுவாங்க. ஐல் பி ஆன் தட் சைட். நாங்கள் 2 பேர் லே பர்சன். இஃப் வி ஆர் மெடிக்கல் பர்சன்னா இருந்தால் எங்களை ஒரு பேரியர் டிவைஸ் இருக்குன்னா தென் ஐ கேன் கிவ் மவுத் பிரீத்திங் கொடுக்கலாம்.
இப்போ வந்து 30 compression ரெஸ்க்யூ பிரெத் கொடுக்க போகிறேன். ஸோ நான் கொடுக்கும்போதே ஐ ஹேவ் டு see just ஸோ 2 compression 2 ரெஸ்க்யூ பிரெத். ஐடியா என்னன்னா நார்மலாக அவங்க எக்ஸ்பயர் பண்ணுற ஏரில் வந்து எக்ஸ்பயர் பண்ணுற அட்மாஸ்பியரில் 21% ஆக்சிஜன், எக்ஸ்பயர் பண்ணுற ஏரில் 16% ஆக்சிஜன். ஸோ அந்த 5% இஸ் நாட் கோயிங் டு மேக் அந்த 16% இருந்தால் கூட போதும். பேஷண்ட் சர்வை வந்துருச்சா சார்?
something is better than nothing.
40%. அதாவது ஒன்று பக்கத்தில் பூ வைக்கிறது.
ஸோ அட்லீஸ்ட் எதுவும் இப்போ வந்து ஐ எம் லே பர்சன் வச்சுங்க. வாட் இஸ் எக்ஸ்பெக்டட் ஃப்ரம் மீ இஸ் a COLS. If a medic person, I have a defibrillator on my side and an airway device on my side, I am expected to give a BLS. இது ஐசியூவில் இருக்குன்னு வச்சுங்க, அப்போ இட் இஸ் எக்ஸ்பெக்டட் டு கிவ் ஃபார் ACLS. அங்கே வந்து ஐ ஷுட் நாட் ட்ரை COLS. அங்கே வந்து ACLS தான் நான் பண்ணணும். அங்கே ட்ரக்ஸுக்கு நான் போயாகணும். ஸோ இந்த நம்ம இது என்னன்னா இதை வந்து ஒரு லே பர்சன் தான் ட்ரெயின் ஆகணும். ஃபஸ்ட்டு COLS போது ஒரு லே பர்சன் ட்ரெயின் ஆகணும். ஒரு ஆட்டோ இது பண்ணுறவரோ இல்லை ஒரு ரொட்டீன் காமன் மேன் ஷுட் நோ ஹவு டு கிவ் எ செஸ்ட் கம்ப்ரெஷன். சரிங்களா?
கவனிச்சிங்க, எல்லா இடத்துலையுமே தி ப்ரோட்டோகால் சேம், ஸ்டெப்ஸ் ஆர் சேம். தட்டி எழுப்பணும், நோ ரெஸ்பான்ஸ், இமிடியட்லி கால் ஃபார் 108 or any medical help, then check for pulse, check for respiration, nothing is there, immediately start CPR. So 2 finger breath above, here, heel of the hand, right hand, left hand. I should be on the right side of the patient. Right side of the right hand. Mostly இங்கிருந்தா ஏன்னா நீங்கள் ஹார்ட் இந்த பக்கம் இருக்கு, நீங்கள் இங்கிருந்து அந்த பக்கம் இருக்கு, அங்கே முடியும். ஸோ யூ ஹேவ் டு பி ஆன் த ரைட் சைட் ஆஃப் த பேஷண்ட். ஸோ லாங் வச்சுட்டேன். அதுக்கப்புறம் ஐ ஹேவ் டு கவுண்ட் திஸ் பை 5 minutes. வாட்ச் இல்லாத பட்சத்தில் மனசுலேயே கவுண்ட் பண்ணுறேன். தட்டி எழுப்புங்க, லோ ரெஸ்பான்ஸ். இப்போ என்கிட்ட சொல்லணும் நீங்கள் 108 கால் பண்ணுங்க.
You call 108, sir.
அடுத்து கரெக்ட்
Correct to see.
10 seconds,
No response.
Then again, no respiration.
So you are going to start
CPR.
CPR start with COLS start.
COLS.
Okay.
Two in the zip is sternum and above that the two
finger.
two finger above the zip is
Yes,
sternum.
sir. Yes. Start. Thirty. 30 seconds. 30 compression. ஒரு gap விட்டு திருப்பி start. 1. 2. பண்ணு. Don't stop. 30. Start. 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 30. பாருங்க எப்படி இருக்கு இல்ல ரெஸ்பான்ஸ் எப்படி இருக்கு இப்போ அடுத்த சைக்கிள் நீங்கள் ஸ்டார்ட் பண்ணோம் அதே மாதிரி 5 சைக்கிள்ஸ் முடிச்சுட்டு ஒரு சைக்கிள்ன்றது 5 செஸ்ட் கம்ப்ரெஷன் சைக்கிள் ஒரு கம்ப்ரெஷன்லையும் அதாவது ஒரு செஸ்ட் கம்ப்ரெஷன் சைக்கிள்ன்றது 30 கம்ப்ரெஷன் ஸோ மினிமம் 120லேருந்து 150 வந்துடும் இல்லைங்களா உங்களோட இதில் என்ன டிஃபெக்ட் ஒரே இருக்குன்னா அடிக்குவேட் ரீகாயில் டைம் இருக்கு இல்லைங்களா அது நம்ம கொடுக்கணும் ஸோ இதுக்கு வந்து ரெகுலர் ப்ராக்டிஸிங் இருக்குது தேர் ஆர் மேனிகன்ஸ் வேர் இட்ஸ் இஸ் அட்டாச் டு ஆப் சார் அந்த ஆப்போட நம்ம கனெக்ட் பண்ணிட்டோம்னா நம்ம சிபிஆர் வந்து வி ஆர் கிவிங் அஸ் அ ட்ரெயினி இட் வில் கிவ் ஆல் தி ரிப்போர்ட் ஹவு எஃபெக்டிவ் வாஸ் யுவர் செஸ்ட் கம்ப்ரெஷன் ஹவு மெனி கம்ப்ரெஷன்ஸ் யூ ஆர் கிவன் வாட் டெப்த் யூ ஆர் கான் எல்லாமே பார்க்குற ஒரு மேனிகன் இருக்குது லெட்டரல் கம்பெனி தே தட் கம்ஸ் அரௌண்ட் சம் 2 lakhs 1.25 2 lakhs கிட்ட வரும் 1.6 lakh it is attached to the app with the app they will go these type of mannequins are used in exams when they are going to give ACLS provider certification போது they use that type of mannequins so அது பண்ணோம்னா நமக்கு தெரியும் நம்ம எவ்வளவு தூரம் பண்ணிருக்கோம் but I tried it in Coimbatore it showed I was only 46%. I thought I had given a very good CPR. It showed only 46%. In spite of so much of training. So you have to do it regularly. Your mind has to get fixed how much compressions you are give, how much adequate time you are going to give. So ideal is 2% because you are going to get fatigue very easily. At least if it is not available or the help is going to come on the way, at least you try 1% CPR. 1% has to start the chest compression. A lay person, he has to do a COLS. If he is a medic person and the availability of defibrillation is there, airway is there, or a barrier is there, you go for BLS. If it is going to be in a hospital ICU setup, then you have to go for a ACLS. That is the basic difference.
And one thing we want to share is in SRM Medical College, they have a simulation lab. Like we do with a basic mannequin of like this. They have a simulation lab where whatever you perform, everything will be traced on the monitor. So it has been connected, electronically operated, and the compression because you can get the ECG tracing on the lab, on the monitor. And once the rhythm it can be programmed like that. Once your cardiac compression start on, once the rhythm regains, automatically you can see the ECG tracing. And you want to try your efficacy, you can see the efficacy, and all will be calculated. So this in Chennai, a good well-established lab is there, which has been constructed, and they do workshops in that lab exclusively for all medical colleges and other thing in that place. And they have that scenario in that we are organizing a conference, state conference in Chennai this year. Our state chapter, Chennai is organizing. We have a workshop on simulation on that lab for 1 day.
Ramchandra Medical is doing ACLS workshop, and Stanley is doing airway workshop, and simulation workshop is being done by SRM Medical College. And the other thing, another important thing, when you are performing CPR, it should be performed on a firm surface. So only I ask the man to be kept down, not at the trolley. You cannot give an effective compression. Or if it's going to be hospital bed, then
it is a firm surface. You neutralize the patient. There are recent breads that are coming with all electronic gadgets where there's a button. You switch it on. It will go for whatever position the patient was kept. It will go for a CPR mode. It will become complete flat, and you can immediately start the CPR. This is available. The Fowler Scott, the latest gadgets there, it is available there. So when you do a compression, it has to be on a firm surface. It's very important. In between, sir. Yeah, sir. Sir, actually, it is not that easy, sir, because the American Council, they tell 100 compression.
Recoil for chest compression, recoil for residual breath, sir. So what you say is chest for every compression you have to allow, sir. It is not 30 seconds is for breath, sir. So once you give a breath for 1 minute, 1 second inspiration, you have to allow recoil for the respiration. This is recoil for the chest compression. Each compression you have to release. So that is the reason when you do, you have that click, double click. So you have to get first click for the adequate compression, second click for the recoil.
The calculation if you are going to take, that is under 120 compression within a minute, that is 60 seconds. I am going to give 120 compression. That calculation by it comes around for 1 second. I have to give within 1 second I have to give 2 compressions. That is 0.5 second. And within this 0.5 second, I have to time the recoil also. So it is not that easy, sir. What we think is we are giving a good CPR. Because if you are not going to give an adequate recoil time, the blood is not going to come into the chest cavity. It is going to stagnate out. So we are going to pump an empty heart. So everything we have to do it regularly, then only we can, but in spite of doing, say, we train, but at least we do a minimal CPR. There is a chance of the patient survive. So once the patient cerebral circulation is maintained, even he may be unconscious. This the ROC would have started, corrected would have started. Immediate help comes. Patient is. We have got so many labs, so many cath labs everywhere. Immediately patient can be shifted to a place where he can be revived. His chances are that rather than not doing anything and looking at the patient, at least we can start with the COLS or BLS.
And that is the reason we have 100 to 120 breaths, sir. At least 50% is efficacy. So that is the reason, because when you do faster and more, at least 50% is an error we will accept. Anything around 50% plus is a good CPR, and 70% plus is a efficient CPR. So once you get trained, you have to get at least 50% pass percentage. That is the reason you have, because once you go deeper, we are more dependent on rate rather than the depth. So that is what the resuscitation principle in child. So we in CPR, because we cannot assess the depth, sir. So we go by the rate. So the cardiac index is cardiac output, depends upon the individual cardiac output per breath, per compression into the rate. So we are achieving the index by the rate principle. So because we are not oriented to the principles of cardiac compression.
And 4 months back we did the COLS program in a DAV school. We taught 400 students, 11th and 12th standard students. So first of all, our idea is to spread an awareness. At least chest compression should revive a patient, should help the patient to maintain his cerebral circulation. So, and we also did in number 2, Rotary. We did again this thing. So idea is a lay person should participate rather than waiting for calling a 108 and taking a video and posting immediately in Facebook. All these things, you at least start a chest compression. You have seen in the video a doctor in the hospital, we lost her. Same patient, some lay person who gave one chest compression, whatever may be the reason, he survived. So the idea of Indian Resuscitation Council is just to spread the message. At least you start a chest compression. The chances are high. The patient to come out is very high. What's the use of getting a cardiac output and respiration with a brain dead patient? No use at all. Sir, please, sir. It's only about 2 mannequins. Please, vanga sister, vanga.
How do you feel? So you have to start another cycle. You should go to the head. Head person should come and start. Until the patient responds. இது நடுவில் நீங்கள் பண்ணிக்கும்போது பேஷண்ட் வந்து நல்லா இருமா ஆரம்பிச்சிட்டாரு கண்ணத்தில் இருந்தால் என்ன முடிக்கல சைக்கிள் முடிக்கணும்னு சொல்லிட்டு ஆரம்பிச்சிட்டாரு சரி கீழே எடுத்துட்டு அவர் வேண்டாம்னு சொல்லிட்டு ரிகவரி அடுத்து
First step system. Not responding. அடுத்து 2, 3. இருங்க ரெஸ்பிரேஷன் பார்த்தீங்களா? ஓகே ஃபைன். இல்லை இப்படி இல்லை நாட் இல்லைங்களா? சரி அடுத்து ஓகே இந்த ஹேண்ட் எடுத்துங்க. இல்லை 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 அங்கே பாருங்க சிபி ப்ராசஸ் ரெண்டு ஃபிங்கர் பிடிச்சி இங்கே எஸ் ரெண்டு கையை லாக் பண்ணுங்க. ஸ்டார்ட் 1, 2, 3, 4, 5, 6, 7, 8, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24. ரொம்ப ஃபாஸ்ட்டாக பண்ணுறீங்க. ரீகாயில் அப்படிங்களா? ரீகால் டைம் கொடுங்க சிஸ்டர். நான் சொல்ல இப்போ 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Tell me 1, 2, 3, 4, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 26, 27, 28, 29, 30. It'll be 1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 20, 24, 25, 26, 27, 28, 29, 30. No. 1, 2, 3, 4, 5, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 30. கொடுத்து திருப்பி இன்னொரு சைக்கிள் 1 மினிட்டுக்கு இல்லை நான் சொல்கிறேன். அடுத்து வந்து செகண்ட் இருக்கணும். அடுத்து அது முடிச்சப்பறம் 2 தடவை 100 கம்ப்ரெஷன் கொடுத்தப்பறம் 7 கம்ப்ரெஷன் இங்கே இருக்கோ நம்ம 2 பேரும் தான் இல்லாமல் இல்லாட்டா நீங்கள் மட்டும் தான் பண்ணிடணும். ஹெல்ப் வர வரைக்கும் யூ ஹேவ் டு கண்டினியூ. நெக்ஸ்ட் ஃபர்ஸ்ட் ரெஸ்பான்ஸ் செக் பண்ணுங்க. நோ நாட் ஓகே. அடுத்து நோ அதுக்கு முன்னாடி நோ கால் யாருக்கிட்ட சொல்லுவீங்க? சொல்லுங்க 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 வாய் விட்டு சினாரியோ ஓகே ஃபைன். அடுத்து தப்பு எங்க வைக்கிறீங்க? நோ நோ பாருங்க இங்க கை வச்சு பாருங்க. உங்களுக்கு கை வச்சு பாருங்க. பாருமா இங்க தெரியுதா? அதே மாதிரி அங்கே வச்சு பாருங்க. நோ கரெக்டட் பல்ஸ் நாட் மோர் தென் 10 செகண்ட்ஸே அதிகம். சரிங்களா?
ஏன்னா ஒரு செகண்டும் இஸ் கோயிங் டு பி லைஃப் கவுண்டிங். சரிங்களா? அடுத்து என்ன பார்ப்பீங்க? கரெக்ட் இருக்கு. அடுத்து இருக்கா? நோ. யூ ஆர் கோயிங் டு ஸ்டார்ட் செஸ்ட் கம்ப்ரெஷன். ஓகே, ஸ்டார்ட் பண்ணுங்க. ஜிபி ஸ்டார்னா ஒன்றும் இல்லை, இங்கே இருக்க ரிப் இருக்கு இல்லைங்களா, இங்கே முடியுதுல, இந்த இடத்துல கை வச்சுனே வாங்க. இதே வந்தோடனே இந்த இடத்துல பாயிண்டடாக ஒரு ரெண்டு இருக்கும், அதான் ஜிபி. அதுலேருந்து 2 ஃபிங்கர் பிரெத் அபவ், இதுதான் கம்ப்ரெஷன் பாயிண்ட். இதுக்கு மேலே இங்கே கம்ப்ரெஷன் பாயிண்ட். கை மடங்கக்கூடாது, ஸ்ட்ரெயிட். ஸ்டார்ட். சவுண்ட் வரணும். 4, 5, 6, 7, 8, 9, 10, 14, 15, 16, 17, 18, 19, 20, 21, 22, 30. இருங்க, ஒரே ஒரு நிமிஷம். கொஞ்சம் ஸ்பீடை குறைங்க. அடிக்குவேட், அதாவது கம்ப்ரெஸ் பண்ணுறீங்க, ரீகாயிலுக்கு டைம் கொடுங்க. ரீகாயில் டைம் கொடுத்தீங்கன்னா தான் பிளட்டு சர்க்குலேஷன் உள்ளே வரும். சரிங்களா? ஸ்டார்ட் பண்ணுங்க. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Start. 1, 2, 3, 4, 5, 6, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 25, 25, 26, 27, 28, 29, 30. Start. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. ஓகே, இருங்க. இது 1 minute கூட முடிச்சிருக்கீங்க. இன்னொரு மினிட்டுக்கு இதே மாதிரி செய்யணும். பண்ணுறீங்களா? பண்ணுங்க. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 22, 23, 24, 25, 26, 27, 28, 29, 30. 30, 30 இன்னொன்று கேப் போடணும். திருப்பி 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, நான் முடிச்சேன். 20, 29, 30. ஸ்டார்ட். 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30. பெட்டிக்காவதா?
We invite our beloved PCMD sir to felicitate our chairperson, Dr. Kusma Matai. Guest speakers, Dr. Bhaskar,
Dr. Giridharan. We are thanking our participatory postgraduates of the Department of Anesthesiology, Dr. Venkat Krishna. Next, final year DNB postgraduate in the Department of Anesthesiology. Dr. Thiru. Thank you, sir. Dr. Ramya. Thank you, sir.
Thank you, sir. Thank you very much. And I really thank Almighty God for giving us a wonderful opportunity for assembling here, and for a very, very life-saving program has been successfully mission accomplished. And I thank our beloved PCMD sir for giving me go ahead for organizing this program, and with his blessings this program has become so successful. I want a big clap of hands by all the participants for our PCMD, sir. Thank you, sir. Thank you, sir. Thank you. And I personally thank our MD madam, Dr. Nirmala Devi, who has made this program come true despite our busy schedule. She has allowed me, even in the last hour, she has extended maximum support and made this program wonderfully well. Thank you, madam. I thank our CMS Madurai, Dr. Sahu, and our CMS Trichy, Dr. Soundarajan, and Madam Dr. Kalarani, and Madam Dr. Madhu Smita Nanda, who have given us their valuable time, and their participation has enhanced our involvement of all the audience, and their participation has really encouraged one and all here. Thank you, sirs. Thank you, madam. And I thank all my senior IRMS medical officers here who have assembled here to encourage all the team and made this program a grand success. And my special thanks goes to Dr. Bhaskar, Professor Omanturar Multi-Speciality Hospital and Secretary of ISA Chennai City Branch, and Dr. Giridhar, Assistant Professor from Stanley Medical College, who is the Treasurer of ISA Chennai City Branch, for making this program really a wonderful experience for all the audience here. And I personally thank all our staff, paramedical staff, and the students, nursing students, and all our attendants, everyone who have made this program, and supportive staff who have given us a helping hand in making this program very successful. Thank you. I invite the audience for some snacks and tea. Thank you, sir.